is, unlike what the name might suggest, not a regulatory body, but actually a medical school. So that's been a point of confusion for quite a while. Yeah. It's like, what is this regulatory guy doing? So it is a medical school in Dublin, Ireland. He completed his PhD in 2016, which was entitled Pharmacoepidemiology and Economic Evaluation of Measures of Potentially Inappropriate Prescribing. So Frank also has an interest in economic aspects of medication. Has experience as a practicing community pharmacist, and is now a postdoctoral researcher in pharmacoepidemiology. And he's for 3 weeks here in Ottawa with us on a Flaherty Scholarship, which is a fund that encourages academic exchanges between Ireland and Canada. And I'm told that it goes both ways, which could be of future interest. And his work overall addresses medication safety. He has an interest in deprescribing, which is one of the reasons why he chose to come to Ottawa, to the mecca of deprescribing, and to spend some time with Pharm. And also an interest in potentially inappropriate prescribing and health administrative databases, which may have something to do with why we spent most of the week with or in our group here. So without further ado, and then he's going on to McMaster for another 3 weeks. So 3 weeks in Ottawa, 3 weeks at McMaster to pursue similar interests and do more networking. So welcome, Frank.
Thanks very much.
We look forward to your presentation.
Thank you. It works. So thanks very much, everyone. So I'm gonna. Thanks for pleased for the lovely introduction. So I'm just going to give you a bit of an overview about some of the work that I've done as part of my PhD back home, and as well as that, some of the projects I'm involved in terms of ongoing work now that I've moved into my current role. So this is my email and Twitter handle if you want to get into contact during or after the presentation. Feel free to do so. So. Just to give a little overview of what I'm going to cover, just going to give you a little bit of context in terms of the Irish healthcare system, to, I suppose, give some understanding around the context some of these results can be interpreted within. A little introduction on potentially inappropriate prescribing. You're probably all fairly familiar with the concept, so won't spend too much time on it. And then cover kind of three main parts of my PhD thesis, so covering pharmacoepidemiology and economic evaluation aspects of potentially inappropriate prescribing, and then just a quick overview of some of the kind of interventional work that has been done and is kind of coming down the tracks at our research centre back in Dublin. So just my conflict of interest, so just as Lee's mentioned, to acknowledge that I'm here because of the James L. Flaherty Scholarship, and also to acknowledge the Health Research Board in Ireland, who both funded my PhD as well as funding the research centre that I'm based at as a postdoc, so I'm indebted to them. So, yeah, as I said, a little bit of background in terms of the Irish healthcare system. So, it's a bit of a basket case in terms of how to, if you decided how to set up a health system, you probably wouldn't do it this way, but this is what we've ended up with. So, it's primarily tax funded. There is some out-of-pocket payments and private insurance as well that I suppose kind of burden sharing with patients directly. The Health Service Executive is the main provider of health services, and particularly in secondary care. In primary care, GPs, so family doctors, and community pharmacists are private contractors who then are contracted by the HSE to provide services to patients. Currently, there's no integration of pharmacists in primary care, family medicine, general practice. So there's particularly in primary care, a big disconnect between prescribers, doctors, and pharmacists working in a kind of high street retail pharmacy. Some patients can access medical services free at point of use through the General Medical Services Scheme. So this is the kind of public tax-funded aspect of the health insurance, the state-provided health cover. So in order to be eligible for that, it's an income-based threshold that has to be met. So people with low incomes are covered under the state-provided health system on the GMS scheme. it also covers most over 70s, so about 96, 97%.
When you say cover, do you mean medication or access to doctors?
So it actually covers both, so both medications and access to doctors and hospital care.
And what about people who have no, like the 60% of the population that have no coverage, what do they do?
So they pay out of pocket to attend GPs, family doctors. They pay for their prescriptions up to a certain threshold. It's capped per month, but it's 144 euro per month, which is about $200 maybe. Yeah. So up to that point, the individual pays. Above that point, the state pays for it. So there's some helping out, but it's a bit of a kind of, I suppose, at the margins that there is some state provided cover there as well. But otherwise, they pay for medications, they pay for doctor visits as well. So there's not much there for the kind of private patients who aren't covered. In terms of from a e-health electronic infrastructure, there's no universal health identifier, so there's no patient number that you can follow a patient through different systems. So each doctor assigns a patient number, each kind of medication scheme has maybe a different patient number, so and no electronic health record or electronic medication record that's shared across institutions or systems. So it's very difficult in terms of providing care and providing continuity of care to deal with that kind of system. Also makes it quite difficult for research to be able to link different data sources together to actually see how patients fare. The Health Services Executive has a few bodies who are interested in medications use, so they have one arm that is worried about the kind of HTA side of things, so the high-cost new drugs to assess whether they're cost-effective or not. There's also a medicines management program which is trying to promote safe, effective, cost-effective use of kind of everything else. So the kind of vast majority of generic medicines and everything that's gone off patent basically and is quite cheap in price. So having said that, they're interested in medications, but there isn't a lot about actual appropriate use of medications within the remit of the health system. So we have focused on this in our research group as a particular interest. So what is potentially inappropriate prescribing? There's lots of definitions of it out there, but so it can be broadly broken down into two main categories. So either potentially inappropriate medicines that are prescribed, so maybe where no clinical indication exists, or use in a way such that the risks outweigh the benefits of the medication. So perhaps being used for too long a duration, too high a dose, or with other interacting diseases or drugs. And then also it can incorporate potential prescribing omissions. So maybe where there is a clinical indication for a drug well supported by evidence, but that drug isn't prescribed for an individual. I suppose a lot of the work in potentially inappropriate prescribing has been in older people, being that as we age, changes in pharmacokinetics, pharmacodynamics, being that the drug's effect on the body and the body's effect on the drug can change over time and predispose individuals to adverse drug events. As well as that, I suppose older people tend to have more chronic illnesses, be taking multiple medications, have polypharmacy, and again, this is going to increase the risk of drug-drug disease interactions with these individuals. So there's been a number of explicit measures used to basically define what is inappropriate prescribing. So some of the more common ones might be the Bruyère criteria, which was developed in the US. But then there's also the likes of the stop-start, which was developed in a European context, but then trying to maybe kind of overcome some of the limitations of beers that not maybe quite so relevant and contain a lot of really rarely used drugs. So to give you an example of what STOP looks like, this is from the original version of STOP. So I, for my thesis, looked at STOP version 1. There has been an update to it, which has added more criteria and indicators, updating them based on current evidence. But I kind of stuck with the original ones just because they came out too late for me. But it's a list of 65 individual criteria broken up by physiological system and defines instances where medication use may be potentially inappropriate. So, for example, long-term use of long-acting benzodiazepines may predispose individuals to falls, fractures, so may be potentially inappropriate. So I'm going to move on now to the parts of my thesis. So my overall aim of my thesis was to assess the validity of measures of PIP in both older and middle-aged people in primary care, looking at the relevance and applicability over time in Ireland, their association with patient outcomes and association with economic outcomes. So I suppose trying to provide some evidence that these definitions of what's inappropriate developed by consensus methods do correlate with adverse outcomes and are important for individuals. So the first part I'm going to present is on trends over a 15-year period in PIPs, as well as looking at polypharmacy, so people taking multiple medications. So the aims of this work were to determine between 1997 and 2012 in a region in Ireland how prescribing patterns and rates of polypharmacy have changed, and as well as that, how the prevalence of potentially inappropriate prescribing has changed, and looking at the relationship between the number of medications being used and the prevalence of PIP over time as well. So this was a repeated cross-sectional study, so basically we took a slice of data for 1997, 2002, 2007 and 2012. And this was from the HSE Administrative Pharmacy Claims Database. So this is for the 40% of individuals who are covered on the public cover for all medications. This is information on their dispensing. So this tends to be a more socioeconomically deprived group than the general population. Within the over 70 category, as I said, that covers most individuals, so they're fairly representative of the full population. We looked at the number of medicines being regularly dispensed to each individual. So looking at the ATC system for coding drugs, we looked at the level 4 ATC code. So this is effectively the kind of drug class level. So statins, ACE inhibitors, and so on. So if an individual swaps between two members of the same drug class, say, halfway through the year, that was counted as all within the one drug class. So we were counting the number of medicines regularly dispensed, so that they got dispensed in at least 3 consecutive months. So something that a patient was probably taking on a regular basis. In terms of the outcomes that we looked at the rates of polypharmacy. So polypharmacy is a funny term, I think, that there's a lot of varying definitions of what it actually is, and probably the most commonly used one is being on 5 or more medications, which isn't actually a particularly useful metric, I think, because it doesn't tell you anything about the safety, appropriateness, or effectiveness of that drug therapy. But for the purposes of this, we've gone with being on 5 or more regular medicines, and also looked at a cutoff of 10 or more regular medicines as well. And wanted to see how, I suppose, the likelihood of having polypharmacy has changed over time. So we conducted, negative binomial regression. So we were able to adjust for changes in age group and sex over time to see the effect of the year on the rates of polypharmacy. Then we then looked at PIP using a subset of 30 stop criteria that were applicable to the data we had. So this was administrative claims data. We didn't have information on diagnoses, morbidity, anything like this. So we're quite limited in how many of the stop criteria we could actually apply to this information. And then we looked at the relationship between study year and having any PIP, and adjusting for, again, sex, not age, because they were all overage, and the rates of polypharmacy from the previous analysis as well, so to effectively control for the effect of changes in the number of medications that were being prescribed. So in terms of the results, in the analysis from 1997, there were about 340,000 individuals included, and this increased up to 540,000 in 2012. And again, a kind of similar increase in the number of individuals over 65 within this group. And interestingly, over time, we saw just under a third of individuals in 1997 had any regular medicine dispensed to them, so at least one. And this had creeped up to, approaching 50% come 2012. So this is a bit of it's kind of giving the game away for the next couple of slides, but this kind of indicated something that might be happening in terms of our medication use. So we then plotted the number of medications, the different colors in the graph. So the white area at the top, the proportion of individuals in each age group who are on 0 medications, then those on 1 regular medicine, 2, 3, and so on, down to 15 or more at the very bottom. And what's happened over time is, this is jumping forward 5 years each time, and you can see a slow, gradual growth in the number of people on multiple medications, particularly in the older and also the middle-age group, so the 45 to 64-year-olds, creeping up in terms of the proportion with polypharmacy, 5 or more meds, or major polypharmacy, 10 or more medications. And you can see this 15 or more segment down the bottom here, which wasn't visible in the first graph, but now suddenly there's a substantial cohort of individuals, nearly 5% of the over 65s taking 15 or more regular medications. So it's quite a stark change over a relatively short period of time. Then moving on to the analysis of PIP. So as I said, we applied 30 stop criteria, and this is kind of looking at the trend over time. So about 33% in 1997, dipped slightly in 2002, and then it's crept up steadily over the intervening years then as well. With this, I suppose we're looking at, so the animations are a bit funny on this. So effectively we have in the purple here the prevalence of PIP, but this is against a background of, as we know, increasing numbers of medications being used. So is that a substantial increase in the number of individuals taking multiple medicines? We probably expect, there to be more medication issues arising just as a result of this increase. I think there's an animation here that's missing, but effectively when we did the regression analysis, the adjusted odds ratio for having PIP in 2012 compared to 1997, once you can control for polypharmacy, it's actually 0.4, so a 60% reduction in the odds of having PIP controlling for the number of medications being used. So actually seems to be prescribers are prescribing more, but doing better as a proportion of all the medications being prescribed. So probably a positive message, but at the same time, one would have to question, is it necessary that individuals are on 60% on 5 or more medications and a bit over 20% on 10 or more regular medications? So this is something that could be, deprescribing might be a solution to reduce this and reduce the risk of PIP further. In terms of the individual hits that were coming up in the analysis, we saw on the left-hand side here, you'll see digoxin at a high dose and aspirin at a high dose has decreased over the study period. And this big one here, this kind of Mount PPI use right here is proton pump inhibitors being used at maximal dosage for greater than 8 weeks. So it's gone from a little under 1% up to 23% in 2012 within this cohort. So that's a really kind of stark shift, and not something that was fully explained, I think, from what we knew about the context in which these were being prescribed. So did try and do a little more work on this, given that once you take that PPI indicator out, the PIP prevalence is actually tailed off over time. So it's kind of driving the increase that we've seen in the last few years. So we looked at all of the individuals prescribed a PPI over this time period. So kind of going from, about 10% of individuals with any PPI prescription up to nearly half with a PPI prescription for the latter 2 years we looked at. Breaking this down then again further, you can look at short-term PPI use or long-term PPI use, so people who had it for greater than 8 weeks, and then break that down by people on a kind of maintenance dose versus on a kind of treatment maximal dose. And as you can see, a lot of the growth is in this treatment maximal dose group at the bottom here. And one step further then, we took out, I suppose, segments which might be medications that might perhaps explain why someone is on a high dose PPI long term. It's not necessarily indicated, but it might provide some justification maybe why there's such a high proportion on a share. So we took out individuals on aspirin, warfarin, and NSAID. But there's still, approximately 5% of individuals with no kind of ulcerogenic medication on a long-term high-dose PPI. So, there might be other underlying morbidity there that we don't know about, but still a fairly substantial proportion of the population with kind of no medication explanation for taking these medicines. We looked at a logistic regression analysis to try and see what factors were associated among the long-term users with being on a high dose versus a low dose. And for some of them, I don't know, you can quite see here with the green in it. So concurrent warfarin use, being on a corticosteroid concurrently for greater than 3 months, these are both are associated with an increase in the odds of being on a high dose, which would make sense. People are more likely to give them a high-dose PPI to protect from gastric bleeds. However, interestingly enough, concurrent NSAID was actually individuals on a concurrent NSAID were significantly less likely to be on a high-dose PPI. So they were more likely to be on a low-dose PPI, which didn't really fully make sense. It could be to do with, I suppose, individuals with some pre-existing gastrointestinal morbidity won't be prescribed NSAIDs because of that previous risk. So the NSAID users might actually be representative of a kind of high risk, high GI risk. I'm sorry, the non-NSAID users might be a high GI risk cohort, which may give that kind of apparently protective effect of NSAIDs. Also, the older individuals, so using 65 to 69-year-olds as the reference category, being 70 to 74 or over 75, again, you are less likely to be on a high-dose PPI. And again, you probably think these are the patients maybe we most want to be, taking an aggressive stance with in terms of trying to protect them from GI bleeds. So again, not fully kind of what you'd expect to see in terms of the factors associated with that high-dose use. So I'll skip through this fairly quickly. So marked increase in prescribing of regular medicines, but accounting for this, prescribing quality has appeared to improve, and the exception being long-term maximal dose PPI use. Some of the strengths of the study, it's a large study population and being able to look over a fairly good length of time. Generalizability, somewhat questionable for the under 65s, under 70s, but for those over 70, it's fairly representative of the population as a whole. Interesting thing, I suppose, the stock criteria version 1 were published in 2008, so some of the criteria that are in that might not have been known to be potentially inappropriate back in 1997, so it might actually have been some of the decreasing prevalences, might have been a case of evidence emerging and being adopted into practice in terms of reductions in, say, digoxin use, high-dose aspirin use as well. And as I said, we don't know about other clinical risk factors like previous GI bleeds, which might be explaining some of the patterns we saw in the PPI prescribing. So implications, more older people on 5 or more medications than previously. So good question, how useful is polypharmacy as a threshold to, maybe flag individuals at risk of, inappropriate prescribing if 60% of the population fall into that category. So perhaps a higher threshold, if you are just going to use a simple numerical cutoff for polypharmacy, might be more appropriate. The increase in prescribing over time could be driven by multimorbidity and acceptance of medicalization, diagnostic creep that might be happening, resulting in more medications being prescribed, or an increase in the use of preventative medicines as more evidence emerges of their benefits in the population as a whole, but that's generalizable to the older population where you see a lot of the use remains to be seen. So, conclusions of this bit, so strategies to address the related challenges of polypharmacy and PIP to further improve quality of care, and should also consider the health systems factors. So as I said, in Ireland, quite a fractured, disjointed health system in terms of the lack of kind of electronic infrastructure. So a lot of the time a GP, family doctor might not know why a prescription was originally started. If it was started by a consultant, there may not be a lot of communication between secondary and primary care. So in terms of someone taking overall responsibility for maybe stopping medications or adjusting medications, they might be less likely to do so if they don't have that full information available. So looking at those health systems factors, so improving that infrastructure might benefit appropriate prescribing in that sense. And so moving on to the second bit, so that was kind of looking at the time trends. Moving on then to the analysis of patient outcomes in a cohort study. So the aim of this was to determine the prevalence of PIP using both stop and start in individuals who are taking part in the Irish Longitudinal Study on Aging. So this is called TILDA. And we had data for them at baseline, about kind of 2009, 2010, and then again 2 years later, a 2-year follow-up.
Sorry, can I interrupt?
Sure.
Before you go ahead here, can you speculate on why there's so much prescribing, such a big increase?
It's probably driven by multiple factors, but I think trying to identify any one thing or even a number of things might be doing it. But as I said, I think that medicalization, as well as I suppose actually having said that, using combinations of therapy for things like hypertension is probably contributing to this as well, that, treatment guidelines are saying, maybe move on from monotherapy to multiple treatments to try and achieve blood pressure control. I think this is probably the time period where that has kind of been instituted into treatment guidelines. So that's also probably going to affect these numbers that you see. Yeah, instead of prescribing one medication at a high dose, we see using multiple medications to try and achieve optimal therapy for individuals. But I still do think there's an element of kind of maybe acceptance that treatment is, for something like high cholesterol, maybe that, people are maybe more likely to agree to take a statin earlier, than previously when they might have said, look, I'm gonna try diet, I'm gonna try exercise maybe first. So again, I think, there's probably a number of things that are driving it, and it's really a confluence of all of those that's leading to such a sharp climb in the data that we saw.
Just a quick corollary to that, is there a subsequent increase in morbidity, mortality outcomes? Like, are there improvements?
I think it's hard to, I haven't looked at it directly, but kind of anecdotally, you probably expect more of an effect from, more aggressive treatment than is being seen. I don't think there's any, equivalent sharp increase in patient outcomes. The thing I've seen a sharp increase in is obviously the drugs budget that kind of exploded over this time. So it actually led to a lot of health systems changes to increase the use of generic use in Ireland, which had previously been kind of not done at all.
I would just hesitate to look at decreases in morbidity or mortality as an indicator of appropriate prescribing. We'd love that to be the case, but since it's impacted by many things before you arrive in the medical system, we're seeing variable rates here in Canada. Some of it is health system dependent, much of it is not.
Sure.
But the exploding health budget is, I think, directly related
That's
to that.
That's a very fair sign.
I think the other thing that would be interesting to look at is adverse drug reactions and ER visits and hospitalizations, because the studies that have been done show wide ranges, but say approximately 25% of ER visits related to adverse drug visits.
Yeah.
So it'd be interesting to look at that over time as well and see if that has changed in a similar way.
Though I suppose as well, the thing is in some of these cases, it might be that, digoxin use is dropping off because there are newer agents that are less likely maybe to cause adverse events. So some of the, some of it, I suppose it's maybe hidden slightly by the fact that, new drugs tend to be safer than older ones that might have been used previously, but again, it would be definitely something to, if we had the data.
I was also struck by the increase in medication. I'm wondering, is it the same in Canada? Does that reflect really that much?
But the thing is, it's not
People coming with a shock.
The high data that increase.
Oh.
Who can prescribe in Ireland?
So it's just sorry, I was going to say just doctors. Doctors and nurses can prescribe also, but there's no pharmacist prescribing.
Nothing changes in that over that time?
The nurse prescribing came in around 2012, but again, it's, it's probably, one, primary care. It's, I suppose nurses in secondary care, I think, would maybe be more likely to be contributing to any level of prescribing. In primary care, there's, I think, not the same number of nurse prescribers out there. So, it's probably unlikely, it may be contributing, but unlikely to be kind of, I suppose, substantial explanation for it.
And it's important to point out that the nurses prescribing are not necessarily nurse practitioners, they're nurses. That's the same in the UK. It's not a nurse practitioner prescribing.
Sure.
Did you look at the physician providers to see if, all ages, genders? I mean, is there any suggestion that there's one group of providers that are
driving this? We didn't look at it because I'll keep using this excuse that our data is really bare bones. There is no information on provider characteristics there.
I just say that because it's hard to believe that all this medicine is good for
I was one of the GP study.
You can pick you out.
You were mentioning you controlled for age and sex. Did you have any other covariates that you were able to control for?
No, it's as a
Yeah,
bare bones
I
system.
think confounding by undocumented factors is probably
Big.
playing a big role.
Yeah, exactly. I suppose it's the things that we could possibly change over the time period. So for, interested in the effect of kind of time change.
You're able to look
So,
at it, yeah, exactly.
But anything that's changed over time that we haven't measured, is obviously going to have an impact. You can't look away. It's basically just the drug, the age of the patient, the gender, and that's kind of it.
Yeah.
So it's very limited.
Okay. Has the first study been published?
It's the two of them published. So I have the references at the end. So one's in BMJ Open, the other in JAGS just before Christmas. So I might just push on through to, so as I said, moving on to the patient outcome side of things. So looking at the Irish longitudinal study on aging, and applying both stop and start. So we had, data problem solved. We have information about morbidity the patients have. So we were able to apply a lot more stop criteria as well as some of the start criteria as well. And the outcomes we were looking at were healthcare utilization, quality of life, and functional decline over time between the baseline and 2-year follow-up. So we were looking at participants aged 65 years and over at baseline. We're followed up after 2 years, and looking at healthcare utilization in terms of ED, emergency department, emergency room visits, GP visits, quality of life, and functional decline. So we had data on medication use from the HSE database that I mentioned previously. So all of the individuals had to be eligible for the scheme. So again, the over 65 group were picking up a high proportion of them, nearly all of the over 70s, and then less of the 65 to 70-year-olds. And then looked at multivariate regression analysis with sensitivity analysis around marginal structural models to try and account for time-varying confounding that might be occurring because we had kind of multiple time points that we were looking at, two we were looking at this stage. So in terms of the actual definition of the primary outcomes, we looked at the number of emergency department visits and number of GP visits reported by individuals in the 12 months previous to their follow-up interview. So it is self-reported data, so there may be issues around recall bias coming into this, but it's kind of the best we had. As well as that, there were secondary outcomes, so quality of life measured by the CASP or 12, so this measures 4 domains of quality of life, control, autonomy, self-realization, and pleasure. And as well as that functional decline, so an increase in the number of activities of daily living that individuals needed assistance with between baseline and follow-up was defined as functional decline. The exposures was the number of applicable stop criteria and start criteria that an individual had in the 12 months preceding outcome measurement. And in terms of covariates, we had demographics, so age group, gender, level of education, living arrangements, whether they were alone, living with other adults, living with a spouse, with the number of regular medicines and reported doctor-diagnosed chronic conditions. So again, self-reported information. So they were asked, has a doctor ever told you you have hypertension, have you had an MI, etc. And then also we're able to adjust for baseline outcome measure, as well as other outcome-specific potential confounders. So even though these individuals are covered by state insurance, some of them also have private health insurance on top of that. So kind of dual cover. So we were able to control for that to see, for example, in healthcare utilization, did that have an impact on any relationship we observed. In terms of the numbers that we had, so there were 1,744 individuals included in the analysis, mean age 76.5 years, and on a median of 6 regular medicines and 3 chronic conditions. In terms of the primary outcomes, 21.7% had reported an ED visit in the previous 12 months, and the vast majority had visited their GP a median of 4 times with interquartile range 2.5 to 6. of the criteria we were able to apply, these were the most common. I don't know if you can see, the text might be a little bit small, but in terms of the stop criteria, which are the blue bars on the right hand side, PPI use is there again. It's a common theme here, as well as that aspirin with no cardiac event or symptoms history reported by patients. As well as the use of an NSAID in individuals with moderate to severe hypertension. So this was objectively measured hypertension at the time of their interview. The omissions that were found to be most prevalent, so for individuals with osteoporosis who didn't have calcium and vitamin D supplementation, as well as that individuals who reported atrial fibrillation or some other arrhythmia or heart rhythm problem who weren't prescribed any anticoagulation, as well as that individuals with asthma or COPD who weren't prescribed an inhaled beta-2 agonist or an anticholinergic agent. We then, as I said, looked at how this exposure to PIP, both in terms of stop and start, was related to the outcomes that I mentioned. So we looked at it as kind of a dose-response relationship, so looking at individuals with 0, 1, and 2 or more stop criteria and start criteria, both in the same model. So I suppose it's adjusting for the fact that someone with an omission might also have an inappropriate medication prescribed. In terms of the significant relationships, we saw for people on 2 or more stop or start criteria, about a 42-45% increase in the rate or the risk of an ER visit. There was also a relationship with GP visits for both stop and start. So in and around a kind of 15% increase in the rate of GP visits for individuals on 2 or more. For functional decline, only omissions, people with 2 or more start criteria had an increased odds of functional decline at 2-year follow-up. And there was also a significant reduction in CAS-412, the quality of life score, for individuals with multiple omissions. So I suppose from this, we can see that both potentially inappropriate medicines and omissions appear to have an impact on patient outcomes, both in terms of a modest increase in healthcare utilization, as well as functional decline and quality of life. Particularly for the omissions, it may be a case to postulate that individuals with omissions have more diagnoses just by default. So it might be a case that these individuals are already perhaps in decline, or it might indicate that someone has maybe stopped a medication because they are aware that a patient isn't well or something like that. So this might be why you see the relationship with functional decline. The kind of decline might have actually started before they had an omission, because a doctor might have decided to stop the medication because it's unlikely to benefit them. In terms of the strengths, so one of the first studies in primary care to use a prospective design to look at the relationship with patient outcomes and demonstrate the impact of PIP in a community sample. We controlled for time varying confounding as well, and didn't impact on any of the relationships that we observed, probably because there's not a lot of time for things to vary over time between baseline and 2-year follow-up. Some of the limitations, so we're using dispensing data for our medications information, so there might be adherence issues here, that even if someone gets something dispensed, they may not actually go home and take it. It might just be in the cupboard or something like that. And as well as that, as I said, healthcare use was self-reported, so there may be an element of recall bias coming into this as well then. But I suppose to show that, or illustrate that if process measures of medication safety like PIP, stop-start, are being targeted, it's important to show that they do actually affect patient outcomes, because even though something might be thought to be inappropriate, it's important to demonstrate that it does actually have an impact on patient outcomes if we are going to devote limited healthcare resources to try and to tackle these issues. And so moving on to the third element, so looking at an attempt to estimate the economic impact of some forms of potentially inappropriate prescribing using a Markov modeling approach. So this was kind of the third part of my thesis, and it aimed to develop Markov models to estimate the economic impact of adverse effects of long-term NSAID use, long-term benzodiazepine use, and PPIs at maximal dose for greater than 8 weeks. And then the kind of secondary aim to this was to apply these models to assess the cost effectiveness of hypothetical interventions targeting each of these PIPs. hypothetical interventions, but it's actually previously published interventional studies. So I'm not sure, is anyone familiar with Markov modeling or economic evaluation methods of this?
Probably most would not.
Perfect. I will give a quick overview, and hopefully the animations will work, or else I'll have to explain a bit more. So Markov models often used for economic evaluations, kind of form of modeling or simulation analysis, and useful where there's a decision between two or more preferred strategies in terms of treatment. So trying to decide between multiple different options targeting one issue. So Markov modeling allows for extrapolation beyond the time period of an RCT. So particularly for something like maybe improving medication adherence, it's a case that the benefits of a patient taking their medication 90% of the time instead of 70% of the time, those effects are probably not likely to manifest within a 2, 5, even possibly 10-year trial. So it allows to actually try and estimate what the economic impact is of downstream effects. So what Markov models involve are changes in your condition of interest, changes in health that might plausibly occur as a result of your intervention versus control, are mapped onto health states. So we might be looking at a condition where someone could be well, they could have progressive disease, or they might die. And effectively, what happens then is, does this work? No, it doesn't work. Okay. So what would have happened is all the little people would have gone through the model. But effectively, what happens is each of the health states is assigned a typical kind of cost that might be associated with it in terms of healthcare utilization costs, as well as a quality value. So a measure of both the quality and kind of length of life for each state. So for example, the model might be run on an annual basis. So each of these states an individual can remain in for a year at a time. After that, they might transition to another state, or they might remain within the same state. So what then happens is you can add probability estimates of someone moving from the well state to progressive disease, probability estimates of someone moving from progressive disease to death. And these can either be from a primary trial if you've carried out a drug trial, or else from literature estimates if you don't have the primary data. And effectively what happens is the model is run once with these probability estimates from kind of your control group. The model's run again with the probability estimates of with the drug, what difference does that make, both in terms of probability as well as maybe costs and quality of life. The model's run over a certain time horizon to basically add up all the costs and quality of the life years over time. And it allows you to calculate a difference in costs and difference in qualities between your intervention and your control to try and estimate the cost effectiveness of your intervention. So the approach that I took using this was looking at, as I said, 3 common types of PIP observed in the Irish population, and comparing them to a non-PIP alternative, and incorporating some of the major adverse events that might happen as a result of being on the PIP. So, for example, individuals taking a benzodiazepine more likely to have a hip fracture, more likely to have other fall injuries as a result of that. So, then in case of mapping out these different adverse events as health states that individuals could transition through. So, everyone started off in the well community, no fall injury state, and then over time they might have a hip fracture and stay in community, a hip fracture, end up in residential care and remain there, and so on, and at all points, like us all, could die. So that was at the bottom here then as well. So the analysis is done on a cohort basis. So we had a hypothetical cohort of 1,000 individuals aged 65 who started off well in community, and then we're basically run through the model based on probabilities taken from the literature for either population studies for kind of the baseline adverse events rate in the general population, as well as then the relative risk of having these adverse events for individuals on a long-term benzodiazepine, for example. Using an Irish health system perspective, so typical costs in the Irish health system dealing with each of these adverse events, and the models are run with a 1-year cycle length, so people could transition kind of at the end of each year. over a time horizon of 35 years up to age 100, and with a half cycle correction because we weren't running it over a lifetime time horizon. The outcomes we're looking at then were the difference in costs and the difference in qualities between our appropriate alternative and our PIP that a patient might be on, with discounting over time to effectively kind of discount costs that come down the road for the patient. Analysis was with Triage Pro and used both deterministic analysis, so this is using our point estimates for our probabilities, so just taking the 1 point that was reported in the literature, as well as probabilistic sensitivity analysis. So this was incorporating uncertainty that might exist, so say 95% confidence intervals around a probability or a relative risk of an event occurring to basically show how certain are we of our kind of top line estimate that we got. So you're all waiting to hear PIPs cause more costs and reduce quality. So as you'd expect, we're comparing something potentially inappropriate to something appropriate. So as you expect, there were higher costs and reduced qualities in the PIP groups. In terms of relative differences, so again, probably as you'd expect, benzodiazepines in the green have the greatest cost and quality difference. NSAIDs have a lower cost difference, comparable quality difference, and PPIs, again, similar cost difference, much less of a quality difference for PPIs. So then, as I said, with the probabilistic analysis, we were able to kind of plot these, so rerun the model, but each time selecting a different value for each of our inputs of probabilities, costs, qualities from a distribution, a probability distribution, to see what the uncertainty was around that, and we were able to then plot them on a kind of cost and quality curve here. So kind of shows the spread of values that you get with it. So up in the green here, the benzodiazepines you can see are fairly certain to be higher cost, reduced qualities. Similar with NSAIDs, not quite as costly, but still all mainly falling within that worse quadrant. And then for PPIs versus maximal versus maintenance dose, you can see quite a substantial amount of the estimates actually fall kind of around the lines of no difference. So there's a lot less certainty around the kind of true adverse effects of PPIs there. As I mentioned then, so that was kind of looking at the overall economic impacts, then trying to model the hypothetical cost effectiveness of interventions, we kind of reframed the decision. So we said, what if we have an intervention to reduce PIP versus no intervention? And then basically plug in these models at the end of the pathway here to see, what is the downstream effects of an intervention that, cuts NSAID, long-term NSAID use by 50%. And did this for estimates from the literature and looking at different willingness to pay thresholds. This is the value that a decision maker or a payer might place on one quality gained. And the typical value for Ireland is €45,000 per quality. And so at this kind of willingness to pay for an intervention, you could spend up to €1,971 per patient as part of your intervention, and it would still be cost effective. And then for benzodiazepines, this was slightly lower, kind of reflecting that benzodiazepines are harder to impact perhaps than NSAIDs. And then for PPIs, lower again, because the, benefit that you're getting in terms of the quality gain is quite small. So it's not kind of providing as much of a net benefit there. So I might just, in the interest of time, kind of fly through this quickly. So as we saw, benzodiazepines, NSAIDs significantly increase costs and qualities. In terms of the practice and policy context, there's very limited implementation of any interventions to improve prescribing for older people in Ireland anyway. And part of this is probably down to there are several interventions that have been carried out, but very few cost effectiveness analyses. So again, providing policymakers with the information to to inform their decision if they go, we can fund this or we can fund something else. If the information isn't there to kind of help them that decision, they're likely to opt for an intervention like this. As well as that, a lot of using cost per quality allows decision makers to weigh up different interventions across different therapeutic categories. So some studies have used cost per prescribing error avoided. So this is useful for policymakers to decide, do I go for this intervention targeting prescribing errors or this one? But it doesn't tell you, should we go for this intervention for prescribing errors or this, intervention to improve care for stroke patients? Which one provides the greater benefit? So that's why cost per quality is very useful. As well as that, there might be little extra funds available. So it's like, new services, a lot of the time, it's not a case of being cost effective. You have to be, cost neutral or cost saving, because the limited healthcare budget that exists can't stretch any further to accommodate it. Implications of this research, so it does provide evidence that there are cost implications for PIP. And yeah, as it demonstrates the potential for market models for medicines optimization interventions to try and evaluate some of the maybe downstream effects for some medication change that occurs. It also shows, I suppose, that there's uncertainty around the adverse events of PPIs, particularly for something that's such a prevalent medication class. It's a bit kind of questionable that we still don't really know what the adverse events of them are, and they haven't been studied sufficiently. So, as I said, adverse events of benzodiazepines are kind of the major one that cropped up here. And yeah, economic evaluation of new interventions should be carried out, and market models might be a way to do this. So I'm conscious I'm nearly out of time, so I'm just going to fly through, it's probably the worst part, the actual interview.
1 to 2 minutes.
1 to 2 minutes, perfect.
Because we really just have a couple of minutes for questions left, so I'm not sure if you'd rather have some discussion rather than present something new.
I might, what I might do is I might just flag what's going on, and maybe you can chat to me about any questions, if that's okay?
It's up to you.
Yeah.
So I suppose just to flag some of so we've kind of gotten PIP is a bad thing, hopefully not. But some of the work that we're doing, looking at improving it, not myself here, but colleagues carried out the OptiScript study. I have references at the end of this. So this was an intervention in about 200 patients using complex intervention using academic detailing with the pharmacist, medicines review with the web-based treatment algorithms, as well as patient information needs to inform them about the options available to them. And I'll skip to the good bit. It was effective, so reduced the odds of having PIP by about 70% in individuals, and this was sustained over time, but it was mainly driven by PPIs that are easy to change, benzodiazepines less so. And then I'll just show you the last couple of bits here. So following on from the OptiScript study, we're currently developing the SPIRE trial, which is another, again, cluster randomized trial, looking at improving medication management for older people, targeting those on 15 or more medications, so those kind of 5% of individuals that we saw in the earlier graphs. And again, it's using a kind of web-based assistance for family doctors to help them to review patients. And actually, recruitment has just begun on pharmacaretrials.ie, so they're facilitating this. Also carrying out a GP pharmacist pilot study, so looking at integrating pharmacists into general practice. This is not done at the moment. So integrating pharmacists within the family health team. So I'm interested in hearing about the experiences over here of that. And then we're also carrying out a pilot of a summary care record. So this is a kind of shared medication record that can be used both in primary and secondary care to help with medicines reconciliation. So we're currently in talks with kind of hospital as well as GPs in the area to pilot this platform and perhaps carry out a trial based on that. So just like to acknowledge my co-authors who helped with the various studies, the HC for providing the data used, as well as Tilda and the participants in that. And yeah, just to acknowledge again the Health Research Board for funding the research, and the Canada University Federation for Foundation for funding my visit here. So thanks very much for your attention.
I have time for one question.
That's a good one.
Yes, we can go.
Yes.
Has this information informed decision-making at the political level?
So we have, collaborating with the GP pharmacist pilot, particularly the medicines management program, so that was the kind of government body looking at appropriate use for kind of the non-really expensive drugs. So they have taken up some of these kind of findings. So they've issued kind of information bulletins around proton pump inhibitors, particularly they're quite focused on costs, so they see this as a kind of a fairly major cost driver. So as part of their kind of dissemination strategy for communicating with GPs, they've made sure to, I suppose, emphasize the findings here in terms of, this is the national level of prescribing in this area, and it's flagged as I suppose, an outlier in terms of benchmarked against other countries, UK countries, this is something Ireland does seems to be particularly bad at for PPIs particularly.
Thank you very much.
No worries, Farrell.
How long are you gonna be around for the break? I presume a
For
few
the
minutes
break,
and then.
we have to leave at about 10 to 10 because we're
Yeah.
going to the annual
Yes.
medicine.
Yeah, that's great.
Thanks for coming.